እንደምን ዋላችሁ ይሰማችኋል?
ሰማናል።
እሺ ምትኩ እባላለሁ። እንግዲህ የጤናው እንግዲህ ከተጀመረ ትንሽ ቆይቷል። ያው ከጤናው ጋር በመተባበር ኤማ ኢትዮጵያ ሜዲካል አሶሲዬሽን እንግዲህ ስለ ሲፒዲ መስራት ከጀመረ ትንሽ ቆይቶ ብሏል። ያው የጤና ባለሙያዎች አሁን በወጣው የጤና ጥበቃ ፕሮክላሜሽን መሰረት የተወሰነ የሲፒዲ ፖይንት በየአመቱ እንዲሰበስቡና ለራሳቸውን ሪኒው ሲያደርጉ እንዳንድ ሪኳየርመንት ተቀምጧልና እሱን ፕሮሞት ለማድረግ ከዛ ውጭ ደግሞ ያው ሰርቪስ የሚፈልጉ ማንኛውም ዜጋ ኳሊቲ እና አፕዴትድ የሆነ ኬር እንዲያገኙ በማለት የኮንቲኒየስ ፕሮፌሽናል ዴቨሎፕመንት ስራዎችን እንሰራለን ማለት ነው። ሶ ኤማ እንግዲህ አክሬዲት የተደረገው እንደ ፕሮቫይደርም እንደ አክሬዲተርም ነው። ሶ እንደ አክሬዲተር የተለያዩ ተቋማትን አክሬዲት አድርጓል እንደ ሲፒዲ ፕሮቫይደር ማለት ነው። ለምሳሌ ጳውሎስን እንዳንድ መጥቀስ እንችላለን። ስለዚህ ሲፒዲ ፕሮቫይደሮች አክሬዲት ያደርጋል ማለት ነው። ከዛ ውጭ ደግሞ እንደ ሲፒዲ ፕሮቫይደር ነው የተለያዩ ኮርሶችን ያዘጋጃል፣ ፕሮቫይድ ያደርጋል። ፕላስ ደግሞ ልክ እነዚህ ከጤና ወግን ጨምሮ ሌሎችንም የተለያዩ ሴሚናሮችን፣ ኮንፈረንሶችን በማዘጋጀት የጤና ባለሙያዎች አብሬት የሆነ ነገር እንዲያገኙ ፕላስ ደግሞ በሰበቡም የሲዩ ፖይንት ወይ ሲፒዲ ፖይንት ኮሌክት እንዲያደርጉና ላይሰንሳቸውን ሪኒው ለማድረግ ያግዛል ማለት ነው። ስለዚህ በዚሁ አጋጣሚ ማንኛውም የኢትዮጵያ ሜዲካል አሶሲዬሽን ሜምበር ወይ ደግሞ ኤኒ ጤና ባለሙያ የዌብሳይት አለ። የኤማ ዌብሳይት ላይ ገብቶ ኮርሶችን መውሰድ ይችላል ማለት ነው። እዛ ጋር ፍሪ ኦንላይን ኮርሶች አሉ፣ እነሱ መውሰድ ይችላል። ፕላስ ደግሞ የመጣ ኤኒቲንግ ስለ ሲፒዲ ማወቅ ከፈለገ ቢሮ መምጣት ይችላል፣ ወይም ደግሞ በዌብሳይቱ ላይ ባለው መጠየቂያ መሰረት መጠየቅ ይችላል ማለት ነው። አመሰግናለሁ።
ቴንክ ዩ ዶክተር ምትኩ። እኔ ሄርሞን እባላለሁ። ጳውሎስ ሆስፒታል እያገለገልኩ ነው የምገኘው። ሳይኪያትሪስት ነኝ። ዛሬ እዚህ የተገኘሁት የጤና ወግን በመወከል ስለ አእምሮ ጤና እንድንወያይ ነው። ለ2 ሰዓታት ያክል ይቆያል ዌቢናሩ። መሀል ላይ ልክ ምትኩ እንደተናገረው ቻት ቦክስ ላይ ሼር ማደርገው ሊንክ ይኖራል። በዛ በመመዝገብ ዛሬ የተሳተፋችሁበትን ክሬዲት ማግኘቱን እንዳትረሱ ሪማይንድ ላደርጋችሁ ፈልጋለሁ። ግን እዚህ መገኘት ያልቻሉ ሰዎች ወይም ደግሞ ያረፈዱ ሰዎች ሬኮርድ ስለሚደረግ ፕሬዘንቴሽኑ ለሁሉም እንዲደርስ እናደርጋለን። የዛሬ ጌስት ስፒከራችንን ሳስተዋውቅ በጣም በደስታ ነው። አስተማሪ ሜንተር፣ ለእኔ ትልቅ ቦታ ያላቸው ሰው ናቸው። ፕሮፌሰር አታላይ ይባላሉ። ያው አብዛኞቻችሁ እንደምታውቋቸው ተስፋ አደርጋለሁ። በሀገራችን የመጀመሪያዎቹ ውስጥ ሳይኪያትሪስት መሃል አንዱ ሲሆኑ ለሀገራችን እንዲሁም ለሀገራችን ብቻ ሳይሆን በዓለም ላይ በአጠቃላይ ብዙ ስራዎችን አበርክተዋል። ከዚህ በዋነኛነት የዛሬን ቶፒክ በተመለከተ የአእምሮ ጤና ለብዙዎቹ ተደራሽ ማድረግ ላይ ብዙ ስራ ሰርተዋል። ከዚህም ያው እኔ አንዷ ፍሬ ሆናለሁ ብዬ ያው አንዷ ነኝ። ከዚህም በተጨማሪ ብዙ ጥናቶችን አበርክተዋል። በተለይ ቡታጅራ ላይ ያለው ፕሮጀክት ለዓለም ሁላ ትልቅ የሚባል ጥናት ነው ያበረከቱት። በዚህም እና በሌሎች ስራዎቻቸው በ2019 ሃርቫርድ ዩኒቨርሲቲ ሽልማት ሰጥቷቸዋል። እዚህ ስለተገኛችሁ በጣም እናመሰግናለን። ወደ ፕሬዘንቴሽኑ እንሄዳለን። ብዙ ነገሮችን እንደምንማር ተስፋ አደርጋለሁ። ፕሮፌሰር
ስክሪኑን ሼር ላድርግ አይደል?
አዎ መጀመር እንችላለን።
ኦኬ ታያችኋል?
ይታያል።
ኦኬ ኦኬ እንግዲህ ስላይዶችን በእንግሊዘኛ ስለሆነ ያዘጋጀኋቸው እንግሊዘኛ ነው መናገር ያለብኝ አይመስልም ነው?
አዎ ይቻላል። በአማርኛ ጀመርን እኛ።
Inshallah. Okay. I would like to thank this organization, Yetina Work, and Emma, and whoever is really organizing this kind of educational sessions. I'm very pleased to talk on the topic that I have been asked to talk on. This is integrating mental health care into primary care. And this has been a topic for many years discussed among mental health professionals, WHO, ministries of health, and different stakeholders on how to make mental health services available to those that are in need and accessible and cheap for their use. So one of the areas that I have also personally been involved in doing is to integrate mental health into existing general medical services to provide the service as close to the beneficiaries as possible. So in doing so, we have achieved really, although still we are far behind where we should have been, but I can proudly talk that we have gone really good steps in terms of integrating evidence-based practice into our primary care settings in the country. But that remains to be scaled up. And actually, my last few PowerPoints would show us that how we've been able to test the proper. Sorry about that. This is a technician who is asking me to stop the generator that's working where I am. So I was showing some kind of signs. So this is the outline of my presentation. I'll do some definitions and burden of mental disorders in the world in general and in our own country, how burdensome, how public health important is mental health problem in our country and the world over is what burden refers to, and the treatment gap or health system response gap to the burden of this huge public health burden of any society. So I will talk about the gap, I mean the treatment gap. And then detection by general healthcare workers in general, what really does detection of mental health conditions by general practitioners like in the world and in our country in particular. And then what is really WHO's recommendation for integration of mental health services into existing primary care facilities and the Ethiopian experience in adapting WHO's integration strategy and what have we've been able to demonstrate. And then I will give the conclusion as to how we can possibly integrate and scale up mental health services in our primary care settings. So the definition is just to define normality as WHO defines normality. It's a state of complete social, mental, and physical well-being, not mere absence of disease. Sorry for the typo. We know that this is what we have been hearing since we were exposed to health field in general. but we don't usually take seriously the mental health aspect of our well-being. That's what we are going to emphasize today on. And then, if that is really the general well-being, definition of well-being by WHO, how do we define mental health? There are different definitions of mental health, but I have chosen this definition that was coined by a Surgeon General of the US. In the US, a Surgeon General is a person who is responsible for mental health, or health general, public health of the country, and advises the president on how health services should be provided. So at one time, a person who was a Surgeon General or in that position defines mental health as a successful performance of mental functions in terms of thought, mood, and behavior that results in productive activities, fulfilling relationships with others, and the ability to adapt to change and cope with adversity. So if you look into those terms that are underlined, mental health deals with thinking, with feeling, mood or emotion, and behavior, our psychomotor act, our thoughts and behaviors and feelings are expressed in terms of psychomotor act, that's called behavior. And as a result of proper mental function, meaning our thoughts, our feelings, and behavior, when they are within normal range, that results in productive activities, fulfilling relationships with others, and the ability to adapt to change and to cope with adversities. That is, in short, what mental health is. So mental health or mental well-being makes up an integral part of an individual's capacity to lead a fulfilling life, which includes the ability to form relationships. This is just social function, study, work, or pursue leisure interests, that is occupational function, and make a day-to-day decisions and choices in a proper and useful manner. So if that is what mental health is, then what is mental disorder? Mental disorder, as a diagnostic and statistical manual of the American Psychiatric Association defines it as a behavioral psychological syndrome or pattern that is associated with distress, a painful symptom or disability or impairment in one or more areas of functioning. This is exactly what any other disease or illness brings about on human beings and animals. It causes distress, suffering, discomfort, painful symptoms, followed by disability. That is exactly what mental health does. It causes suffering, it causes pain, big concern, and pain, sometimes psychic pain, could be, although not appreciated by many people, especially those that have not been really closely working with mentally ill individuals or has read about it. The pain, the psychic pain people can undergo when they are mentally ill is not well appreciated, but it can be one of the severest pains, psychic pain. It's not a pain that originates from our nerve endings, but it's a psychological pain that you cannot properly measure, but it can be very painful. And that's why people often take their lives because they don't see life as something worth living because of the suffering they undergo. So it is a painful pain. Psychic pain can be very painful. And that's what mental disorder is. It is a distress, a discomfort, psychological discomfort that results in disability as any other disease or ailment does. So is it something that we need to discuss really? Is it a public health importance? Why do we need to talk about mental health problems? What is the degree of its burden as it is measured by different epidemiological methods? So burden of disease in general measures the impact of living with illness and injury and dying prematurely. So that's how the burden of disease is measured in general. The summary measures disability adjusted life years, measures the years of healthy life lost from death, premature death in particular, and illness. And that is, in general, is the sum of years of life lost due to premature mortality or and the years lived with disability. That's this measurement has helped actually many policy makers to make a rational decision or give due priority to mental health services, because mental illness is not directly a killing disease. As a result, it has not been able to get proper or due attention by policymakers, health planners, and health workers in general. But after the advent of this measurement, disability adjusted life years by public health specialists, mental health has gotten its, not yet still, but better attention by policymakers and health planners, because years lived with disability is more prominent with cases of chronic mental disorders than with other conditions. So that has opened eyes of policymakers and health planners to give at least somewhat better attention for mental health services. So when we come to certain figures that indicate, sorry, how burdensome mental health problems are, WHO estimates 1 billion people are affected by mental disorders just today as we speak. People with mental disorders experience disproportionately high rates of disability and mortality. I said earlier that mental disorders are not directly killing disorders, killing conditions or diseases, but they are one of the leading factors for mortality, premature mortality, compared to other conditions in the general population. For example, persons with major depression and schizophrenia have 40 to 60% greater chance of dying prematurely than the general population. Our own study in Butajira has shown us that people with schizophrenia, depression, bipolar disorder die 20 years prematurely compared to the general population. You can ask me later on why does this happen and how it happens. We can discuss about it. And suicide is the second most common cause of death among young people worldwide. Because young people are not likely to die from other causes, so the leading cause of suicide is a leading cause for mortality in the young population. 9 out of 10 suicide cases are happen because of mental illness. Taken together, mental, neurological, and substance use disorders account for 13% of total global burden of disease, as it was estimated in 2004. This is a big proportion. I mean, taking all diseases that are known to mankind, and when the burden of the total disease burden of all known diseases in the world, mental and neurological and substance use disorders contribute 13%. That's a big burden compared to other conditions. Depression alone accounts for 4.3% of the global burden of disease, and is among the largest single cause of disability worldwide. 11% of all years lived with disability globally are attributed to depression. Particularly, this is true of women. A recent study estimated that the cumulative global impact of mental disorders in terms of lost economic output will amount to 13.33 trillion between 2011 to 2030. Mental disorders frequently lead individuals and families into poverty, homelessness, in the United States. So incarceration due to different offenses takes place in many other countries. I don't think that is true in our country, but in many countries that happens. Burden of mental health problems is also now associated with poverty. Our own study in a district, in Sodo district in Gurage zone, has shown that this is the area where we tested integration of mental health services that I will be talking on later on. One of our PhD students did using that opportunity of a big project that we had in Sodo district. His assessment on severe household food insecurity was reported by 32.5% of people with severe mental disorders, compared to 15.9 or 16% of responders from comparison households. These are households that had one or two people with mental illness were compared with others that had no member with mental disorders. And those with mental disorders had 32.5% of those individuals with those households with an individual or two that had a person with mental disorder, severe mental disorder, reported that much food insecurity. Whereas in the general population, in the comparison group, it was 16%. Of 300 people with severe mental illness and severe mental disorders mean the same thing. I'm sorry for the confusion. 25% of mentally ill, severely mentally ill people were under restraint in that particular district when we were doing the survey. So you can imagine the kind of burden mental disorders have with their disability, restraint, homelessness, unproductivity, premature deaths, and all these are really adverse circumstances that we see when people are mentally ill. Mental disorders that contribute to burden of disease are depression, bipolar affective disorder, schizophrenia, anxiety disorders, dementia, substance use disorder, intellectual disabilities, developmental and behavioral disorders, including autism. These are the leading problems among mental disorders. When we talk of mental disorders, we are, well, if we try to enlist mental disorders, they are close to 300 different types of disorders. But now we are talking about priority disorders or high disorders that bring high impact or high burden in any community. So these are the leading causes of disability, premature mortality, and years lived with disability. Our own study in Butajira in 1998 showed that depression and schizophrenia accounted for 11% compared to all other diseases enlisted here, as you can see, contributed to burden of disease in that particular area. Depression 7%, schizophrenia was 4%. So this being the burden, has really the health system been able to respond adequately to this high burdensome public health problem in the world in general. Health systems have not yet adequately responded to the burden of mental disorders. Between 76 to 85% of people with severe mental disorders receive no treatment for their mental and neurological and substance use disorders in low and middle income countries. Even in high income countries, between 35 to 50% do not receive adequate care. Globally, annual spending on mental health is less than $2 per person per year, and less than $0.25 per person per year in low-income countries. So you can see what the gap looks like compared to the burden I was talking about earlier. The number of specialized and general health workers dealing with mental health conditions in low and middle income countries is grossly insufficient. Almost half of the world's population lives in countries where on average, there is only one psychiatrist for 200,000 people or more. Our country actually used to, the ratio between mental health personnel and population ratio used to be 1 to 1 million or 2 million until about a few years ago, where we started training psychiatric nurses and psychiatrists. Now our ratio is close to this. Other mental health care providers like psychologists, social workers, and others are even scared. Only 36% of people living in low-income countries are covered by mental health legislation, compared to 92% in high-income countries. There are countries to obligate the governments and policy to influence policy have special mental health legislations to guide and also obligate governments to allocate adequate resources and address mental health problems properly. They have legislation, and 92% of high-income countries, whereas in low-income countries, only 36% of the countries have mental health legislation. One of those countries that have no mental health legislation is our country, Ethiopia. When we see really treatment gap compared to other non-communicable diseases, physical disorders like diabetes in high-income countries this is actually a treated prevalence of disorders. Diabetes, 94. In low-income countries, it is 77. Heart disease, 78 in high-income countries, 51 in low and middle-income countries. Asthma, 65% in high-income countries, and 44% in low and middle-income countries. When it comes to mental disorders, depression, even in high-income countries, only 29% of those who suffer from depression get treatment. And in comparison, it's only 8% in low and middle-income countries. Bipolar disorder is the same, and panic disorder, as you can see on the table. So there is generally very low treatment or treated prevalence of treated individuals in low and high income countries. But in low income countries, as you can see, it is really the situation is miserable. When it comes to detection of mental disorders in general health facilities, a Kenyan study, well, there are several studies actually. One of really a very good study that was being quoted worldwide was done in Ethiopia in the 1960s by Professor Robert Gill, who started the Department of Psychiatry at Addis Ababa University, my department now. And he conducted a study at the Ekati 12 Hospital in 1969. And he found out that among the outpatient attendees, 18% of those attendees did so because of psychological problems and did not have any other problem, but they had these somatic symptoms, manifestations of certain psychological problems. So, whereas in comparison, in that same study, 16% of people came because of infectious diseases. So, however, none of those people who complained of vague, non-specific psychological somatic symptoms were identified as having mental problems, mental disorders in that study. So this Kenyan study showed that 42% of study participants had symptoms of mild and severe depression. Of those, it's only 4.5% that had a working diagnosis of a psychiatric condition. So you can see the discrepancy between the prevalence of mental health conditions among general outpatient attendees and the detection rate by general health workers. Our own study in Sodo, this is the study areas that I'm going to talk about later. Out of 1,014 participants assessed in primary care, only 13 individuals, 1.3%, were detected as having depression, whereas a systematic, the same population was assessed using a screening tool called PHQ-9. This is called public health questionnaire. And that had nine items. The prevalence of depression in that population was 11.5%. So now, when we see, this clearly shows us that there is a policy gap. There is also a systemic gap to address mental health conditions, and the the scarcity of resources, scarcity of trained human resource, the unmet needs of mentally ill individuals in all societies, particularly in low and middle income countries, is immense. So the solution for this gap, to close this gap, is integrating mental health services into primary care. It is the most viable way of closing the gap. Primary care for mental health is affordable, and investments can bring about really important benefits. Certain skills and competencies are required to effectively diagnose, assess, treat, support, and refer people with mental disorder. It is essential that primary care workers are adequately prepared and supported in their mental health work. This is what WHO is advocating. According to WHO has really drawn this World Health Service pyramid for an optimal mix of services for mental health. As you can see here, in the bottom, many of people with mental illness are cared by themselves, by the family, or by different means within their households. And the next level is informal community care. Different traditional healers, religious and traditional healers, are the ones that take care of the majority of people with mental illness in low and middle income countries. And then mental health services at primary health care level and community mental health services. There are actually community mental health services. This is specialized care in high income countries, and psychiatric services in general hospitals, and long stay facilities and specialized services. This is a situation, and we cannot avoid this situation, is what WHO is saying. There is a fair estimate on the magnitude of unmet needs in low and middle income countries in general. The main gap in knowledge is, we don't know how to integrate. That is the main difficulty. Ever since I came to get introduced to mental health training, I have been hearing from WHO and many different experts, integration is the best thing really to bring about good coverage for mental health services. But nobody was really clear as to how to integrate mental health services into existing primary care settings. And there is really a gap in knowledge on how best to meet the needs. And the late Professor Gale, our mentor, the guy who started the department here in our country, argued 40 years ago that if mental health services are to be expanded to address mental health needs in low and middle income country, he said two things have to happen. One is certain disorders have to be prioritized as targets of intervention given the resource constraints in low and middle income countries. Two, mental health care has to be provided by non-specialists through task sharing and integration into mental health, into primary care. This was what he said actually many years ago. Having done different studies in different outpatient settings here in Addis Ababa and in Jimma area, in Bonga, he came up with this conclusion. And that still holds true, and this is exactly what World Health Organization is now trying to do, integrating mental health services into existing primary care settings. WHO says there are 7 good reasons for integrating mental health service into non-specialized healthcare. The burden of mental disorders is great. Mental and physical health problems are intertwined or interwoven. The treatment gap for mental disorders is enormous, and it will enhance access to mental health care, promote respect of human rights. It is affordable and cost-effective, generates good health outcomes. So these are good reasons for integrating, according to WHO, integrating mental health services into primary care settings. However, a task force that was looking into facilitators and barriers of integration of mental health services, that was set apart by World Psychiatric Association in 2011 did some kind of study in the African settings. And this was our conclusion. Why is it difficult for mental disorders to be integrated into existing primary care settings? These were the reasons that were given by different African mental health experts. We distributed questionnaires and we summarized it like this. Because of other competing priorities, wanting community engagement, reliance on community volunteers not sustainable, the difficulties we have, it is underfunded, paucity of mental health professionals, negative attitudes to mental health care service, concern about skills of staff, difficulty sustaining it, erratic supplies of psychotropic medication, lack of multi-sectoral collaboration, and escalating need and demand for other services. Having all these problems and other reasons into consideration, WHO came up with a strategy on how to integrate mental health services into primary care settings, both in low and high-income countries. This is by developing a guide that can be easily used by primary care workers, clinicians at different levels, in our setting, by nurses, health officers, and other clinicians and general health practitioners. But in other countries, family physicians, GPs in Europe, they call them GPs in the UK, family physicians in the North American settings. This tool can be used by those individuals after training. And it has been developed by WHO and released. It is called Mental Health Gap Action Program. It is a tool that provides evidence-based guidance to identify and treat primary mental disorders at primary care level. And WHO launched this tool in 2008. This is meant to bridge the gap between available resources and the large need for mental health services. MHGAP is an intervention guide released. It was released also, it was developed in 2008 and released in 2010 to help non-specialized, specialist care workers to detect and treat primary mental conditions. It has been tested in many countries, including ours, and this tool, this guide, has been translated into 20 different languages and now being used in 90 different low and middle income countries. So it has now, I think it is on its third revision now. All that it is dynamic, WHO is revising it. It has an expert group Professor Ababao and Dr. Charlotte are now included in the task force, WHO task force for MHGAP. MHGAP IG is intervention guide, and the second version enlists the training modules. It has a training. The training is supposed to be only for 2 weeks, as WHO puts it, a 1 week training, theoretical training, 1 week clinical or practical training, and then people would be sent to primary care settings. But the stipulation is that there has to be also a supervisor, a trained mental health specialist, could be a psychiatrist, a psychiatric nurse, or a mental health officer. They call them in other African countries, but here we call them psychiatric nurses, or there is another name. Now, actually, we have people that are being trained with master's degree, specializing in mental health conditions. So those people can be used as supervisors until really primary care workers enough confidence to detect and assess, detect, diagnose, and initiate treatment and follow those conditions. So there are these are the conditions. So the module of MHGAP contains essential care and practice. That is, the principle of care and practice is one module: depression, psychosis, epilepsy, child and adolescent mental and behavioral disorders, dementia, disorders due to substance use, self-harm or suicide, other significant mental health conditions. These are like stress, and grief, or different other somatic complaints that may not fit into the diagnosis of those disorders mentioned above. So this is a package MHGAP has. So MHGAP has it has a different guide for trainers, TOTs, and supervisors have their own guide and training. After that, those people who took TOTs would train the actual primary care workers, and supervisors also get the training on how to supervise these clinicians in the primary care. So what did we do with using this in our country, and what outcome did we achieve as a result of the test we did in Ethiopia? As you know, in Ethiopia, many different epidemiological studies in different population groups have been conducted, and good evidence has been generated on the burden and treatment gap. You can see actually some of many in the literature, our studies are being used as evidence for treatment gap. In our study in Butajira, we found out that people with severe mental disorders had 90% treatment gap. We found 10% of individuals that had schizophrenia, depression, and bipolar disorders had at least one visit to a Manuel hospital, but less than 1% had a continuous follow-up and treatment at a Manuel hospital. So we have contributed a lot to generate evidence in that regard. So evidence-based intervention trials have been conducted, and integration of mental health services has been tested. And this is what I'm going to present to you. And Ministry of Health also in its health sector development plan has included mental health as one of the priority conditions to address and also to measure. In 2010, and the integration of mental health, it stipulates that 50% of primary care will be managing mental health conditions, and the MH gap was piloted in 4 different regions. A scale-up plan was also there, and it was also launched. However, evidence on how best we can approach this integration was, in our opinion, missing. Because of that, one of our research projects, had the opportunity to try on how best we can implement MH gap in primary care settings. This is in Sodo Health Center. This was made possible through a project called PRIME. PRIME is a program of improving mental health care. That's an acronym. And this was actually conducted using a fund obtained from the UK government. And it was a big consortium. Different countries were involved in this integrating mental health intervention into primary care. And we were one of those countries: Nepal, India, Uganda, South Africa, Ethiopia, and WHO were members of the consortium. And we took this opportunity to generate really good evidence on how best we can apply mental health gap training and supervision to the level of bringing clinicians at primary health care to a level where they can properly detect and treat mental health, especially severe mental health conditions like schizophrenia, bipolar disorder, and depression, and alcohol use disorder. So this was a really development of a scalable mental health care plan. We did really think through. This was led by Professor Ababa, and we did a really very good plan, district mental health intervention plan. And the key questions that we tried to, areas that we wanted to involve were what kind of organizational or systemic support is needed. The system has to be supported in order to implement this program, and what kind of capacity strengthening was needed at primary care level. What is the best approach to improve accessibility with the community level, district health level, and at health facility level. So we did situational analysis. What kind of services are available? What are the risk factors that might contribute, peculiar to that area? And we also did asset mapping, meaning what are really possible support sources that the community has when they're faced with mental disorders, and theory of change workshops with different stakeholders. Theory of change is really, this is a method you discuss with individuals on how to achieve the ways you need to take, the steps you take, and outcomes of each step to get to a desired goal. And this is also done using different workshops with the community, with health workers, and community advisors and many different stakeholders. And we did also a qualitative study on this problem. The situational analysis, asset mapping, theory of change, and qualitative, the purpose of doing all those were indicated here. So for the sake of time, I'll skip those. So we did a qualitative study on feasibility, acceptability, integration of mental health care, including staff from Ministry of Health, District Health Office, primary care, facility, health development army, traditional and religious healers, families who had mentally ill members. We did really this qualitative study to understand how they would perceive and what their proposals would be on how to integrate mental health services into the existing health service. This is mental health care plan. This was in the community, health facility, and healthcare organization level. So in the community, we engage the community, especially using the health extension workers on case detection and reintegration of mentally ill when they are treated, and inclusion in the social system, and health facilities with capacity building, decision support, supervision, and all other stuff, and staff well-being were included in the training manual. Organizationally, with district health office, program management, supervision, sustainability issues were discussed. And after this, we focused, since now our focus today is on integration. Intervention package where different levels were developed for clinical staff at the health center level. These are nurses and health officers that were directly involved in assessing and managing the mentally ill individuals. And we also did a sensitization workshop of the whole health center staff of Bui Health Center, and supervisory support was given, and the staff well-being was also one of the areas that we had to include in the training package. The aim was really to enable clinicians to have good capacity for case detection, identification of psychosocial risk, prescription of medication, provision of basic psychosocial support, referral when necessary, and ongoing care. This is using a MH gap. By the way, WHO says 2 weeks is enough to do to give MH gap training, and that will enable primary care workers to diagnose and manage individuals. But we didn't find it to be really enough, so we had to take longer time, and we trained them for about, I think, nearly a month, I would say. So after training, we pilot tested, and in a health center where there was no one being detected as a case with mental disorders, after training, we found this total of 26 cases were identified within 1 month in one health center. Psychosis, depression, suicidality, mild depression and other disorders, alcohol use disorder. Those trained clinicians were able to detect this number of cases, while none used to be detected in the same health center before they had this training using MHGAP. And then this was scaled up in 8 different health centers. And after, and of course, with adequate support and supervision by psychiatric nurses, general health officers and nurses used to were handling cases. And then after 12 months, we wanted to see the outcome. 6 and 12-month outcomes were measured. Primarily, the outcomes were on detection and symptom severity elevation and disability, and secondary outcomes were discrimination, restraint. Many people were restrained and many were homeless at baseline. Then after the training and 1 year later, almost 94% of public health, primary health care workers diagnosis of severe mental disorders were verified by psychiatric nurses. So they were able to detect 94% of the cases that had real treatable mental health conditions. All prescriptions were also assessed. Clinical audit was done, and they were within the recommended dose limits. And a total of 245 or 81% people with severe mental disorders were reassessed at 12 months again, and with the diagnosis psychiatric nurses, and minimally adequate treatment was received only by 29%. So 70% of the cases that were seen by primary care workers were prescribed with adequate doses. All clinical and social outcomes improved significantly. Being restrained in the previous 12 months reduced from 25.3% to 10% after 12 months. So this is a significant change that was brought about due to the intervention given by primary care workers through integration and training using WHO developed MHGAP intervention guide. And a total of 239 people with severe mental disorders and 27 control, 274 is that? And 96% control households were assessed after 12 months. This is actually for poverty, food insufficiency, food insecurity index. We have different tools to measure all these things. So food insecurity status after treatment of these cases with severe mental disorder had improved in 51 or close to 52% of those people that had food insecurity had improved compared to people or households that had no, an individual with mental illness had only 39.7% improvement because they had baseline is also better. That's why probably the difference was such exaggerated. So symptom reduction was related to reduction in food insecurity. In conclusion, well-planned integration of mental health services has good outcome. Short-term training of clinical staff, nurses, health officers using MHGAP, IG, or guide enables them to detect and treat severe mental disorders. It reduces clinical and social impairments, thereby reducing the burden. It is cheaper and it is accessible. So if we train non-mental health specialists using WHO the WHO MH gap intervention guide, we can significantly reduce the burden of mental disorder treatment gap in the country, and also we can easily integrate mental health services into primary care. I was not very technical on how the training and the detection and everything was done, because it is very difficult to do it in 1 hour. So I think for those who are interested to handle cases with mental disorders, those of us who are working in general hospitals, outpatient departments, and health centers, and wherever we are, taking training of MH gap would be very useful to detect, screen mental health conditions in our general medical setting, and that would bring a lot of change in the society, including clinical outcomes, social outcomes, economic outcomes, and many outcomes have been measured, and I have not covered all of the good outcomes. And the district has now taken this service over, and they make psychotropic medications available in those health centers, and they have set aside a unit within the district office to help and supervise the general health workers. And of course, because of turnover, ongoing training is also essential in those settings. If Ethiopia takes this into, Ministry of Health takes this seriously and scales it up, it will really help minimize the treatment gap of mental disorders. Thank you very much.
Thank you, Professor. So we can open the floor for questions. If any of the audience has any questions to Professor Atalay. There is one. There are multiple questions on the chat box. I can read them out loud.
Okay.
The first one is, are the mental health gap training available virtually? MH gap training, I think.
Well, I'm not sure. I don't think it is available. And it may not be that useful also, because there is a group work, there is interaction, discussion, and also particularly for the clinical training, people have to be available physically and take clinical training in the clinic. So I don't think so, but we can inquire. I don't know if WHO has that kind of modality in training. I'm not sure, but I'm not aware of. But I suggest that we need to be physically there, because it requires practical training as well.
So the next question is, what's considered short-term training? From Helena.
Yeah, short-term training is anything less than a training period that requires specialist training is a short-term training by definition. But WHO expects actually this training to take only 15 days, 2 weeks. Even 1 month is short-term training, in my opinion. 3 months is even short-term training. So it takes, really, in our experience, especially the clinical training, should be at least 2 weeks. 2-3 weeks would be really good time to develop good skills and understand and to assess and make proper diagnosis.
Okay. So Samira is asking, saying, thank you, Professor, for your thorough explanation. How many primary health care facilities were we able to reach so far?
Well, unfortunately, not many. Actually, we did this study in Soto, Warada, which had 8 health centers. And we have presented this. The Ministry of Health is also a partner in this study, by the way. And it takes really enthusiasm and good planning to take this over and apply it to other health centers. But our study covered only 8 health centers.
Yeah. I think there are also multiple health centers trained by the ministry and other NGOs, WHO included.
Yeah, I think so. Yeah, that's true. Yes. The problem with that kind of model is it's not enough only to train health center staff, the clinicians. It is important that the district health bureau people also get the training and be made aware of really the continuity of care, particularly making psychotropic medications available and supervision, and including it in their HMIS and adequate supervision is very, very important. Without that, just only training primary care clinicians and expecting good outcome as we did in the Soto district is not possible.
The same person also asked if MHCAP is effective in our setup, how effective it is in our setup.
Well, you know, the effectiveness as we tested it is very effective. I just showed you. Actually, we had different measures really to measure the impact of using MHCAP training and implementing it properly with adequate supervision, support, and maintenance system, and making all the necessary supplies available. It brings really, the impact is tremendous. As I told you, the detection rate was 94%. The treatment assessed, the quality of treatment was within normal range. Only 29% had minimal, because, you know, it's usually, unfortunately, people, non-specialist people tend to undertreat, even when they prescribe a proper medication. The undertreatment is a common problem. So 29% of those cases were undertreated, but in terms of detection, 94% of the cases were properly detected. And there was no overdose or inappropriate kind of treatment. And in terms of outcome, proper identification and initiation of treatment was measured, and people who used to be restrained and homeless, I didn't report actually the homelessness. Homeless people, after being treated by these primary care workers, have become now well integrated in the family, and they live in their homes. And restraints, as you can see, 25% restrained. After 1 year, that was reduced to 10%. And the poverty index, I mean, the food insecurity index has greatly reduced, and the productivity of those individuals that were treated by these primary care workers was really impactful. So this is the kind of effectiveness, how you test the effectiveness of a certain intervention. And I'm sure there are also other outcomes that we measured, but that now I don't remember all of them. So it's effective.
A follow-up question on that. Do you think, in your opinion, it would be best, the outcome would be better if GPs and other health professionals besides primary health care workers were trained with MHGAP?
Absolutely, absolutely. Actually, in other countries, you see, ideally, our health centers should have been staffed with family physicians. That's what's meant by primary care work in other countries. But in low and middle income countries like ours, we can't afford. We should have been really able to do that. We had started this. Butajira Health Center, when we started our studies there, had 8 general practitioners in the health center. Now there is none. So, and even in primary hospitals and many other outpatient units, training general practitioners using MHGAP would absolutely change the treatment gap significantly.
So,
and it is meant, actually, when they developed it, it is meant for those kind of individuals. By the way, WHO developed it for doctors.
Nehemia Dargato is saying, thank you for an engrossing presentation. My question is, the attitude of the existing healthcare professionals towards the provision and integration of mental health services is lacking, in my opinion. In your experience, is this a major challenge in integration? And if yes, what can we do about it?
Oh.
Was the connection?
Yeah. There was interruption.
Okay. So the question again is, sorry, I think it's my connection. What's the attitude of the existing healthcare professionals towards the provision and integration of mental health services? And in your experience, is this a major challenge in integration? And if yes, what can we do about it?
Yes and no. It used to be the attitude towards integration used to be negative and very difficult in my experience. When we started training psychiatric nurses and deploying in different regional hospitals, it was very, very difficult to get really acceptance by our colleagues, hospital rectors, and different specialists in those regional hospitals. Was very difficult. But now, I think things are changing very much. The awareness and the interest in helping mentally ill among health workers has changed greatly, in my opinion. But still, there is still that stigma that has become a barrier to properly integrate. And that needs to change. And that will change, really, in my opinion. Over the years, I have seen a great change coming among our colleagues in different hospitals and other fields of medicine. So, and also, this is because, everybody is directly or indirectly affected. well, if we discuss, if we're honest now in the audience, we have someone in our family or distant or close relatives are somewhat affected by one or another kind of mental illness. So that also brings about change in our attitude and practice about mental disorders. So I think now things are favorably changing, in my opinion.
Yeah. I don't see any more questions on the chat box. Okay, there's one, sorry. Thank you, Professor Atalay, for your tireless efforts and contributions in improving access to mental health service in Ethiopia. We are also very fortunate to attend your presentation today. Do you think integrating mental health services with the health extension package is feasible? And do you believe, oh, sorry, another chat came in. Okay, do you think integrating mental health services with the health extension package is feasible, and do you believe that can improve access to basic mental health service? My name is Bikaseng Asrat. Thank you, Bikaseng.
Okay, thank you. Thank you, Bikaseng. Yes, of course. Yeah, we have actually, well, mental health has been included as one of the packages. I don't know, you know this, Herman, yourself about this. Yes. Yeah, so mental health in this study, in the BUI study, we have included health extension workers, and their role in this care is, one, we actually, not only health extension workers, community leaders were also involved in detecting cases, severe cases. It is very easy to detect. We gave them vignettes and asked them if they knew anyone that fits the description that we gave them. And they were able to identify and send cases. So that's how we identified in Sodo district, 300 people with psychosis and epilepsy were identified. And all of them, when they came and assessed by clinicians, 100% detection rate. So we can use health extension workers to detect and refer, and also to follow the default rates and encourage people to continue taking their medications, and also train them on how to recognize relapses and advise the family to come to the health center. So there are several things that we can use health extension workers for in the care of mentally ill. Absolutely, yeah, they can be involved in, it is feasible actually to use this, to use health extension workers as team members in this integration of mental services into a health center.
Okay, so there is also another question. Thanks, Professor, for such an interesting presentation. My suggestion is to work on accessibility of healthcare for those clients with mental health problems, and better to intervene at program level in preventive aspects, which is better to early curb the problem. I think that was more of a comment.
That's absolutely true. Actually, if you involve, the community has to be involved, and the health system, the district or the zonal or whatever. So far, actually, the problem that I have encountered over the years is that the regional health bureaus and the Ministry of Health, the disintegration rather, has created a problem in integrating mental health services, because all what we discuss and decide at ministry level has proven to be very difficult to take it down and implement it at the regional level. Now, if you go to district level and engage people, they're very receptive, and we have seen a lot of change in that district when we tried to do this intervention. So if we do the intervention at community level, we're using health extension workers and community leaders, and at the health system level, using district health offices, and at health facility level, using our clinicians. I think a lot can be done in terms of prevention, particularly in Sodo, for example. One of the things that in the group discussions, in qualitative studies, and the community leaders discussions, alcohol problem in that district was raised as one of the major public health problems in the district. We never thought about it. And when we did a survey, the prevalence of problematic alcohol use was very, very high. You cannot imagine, in the district as a whole. So they came up with this idea. We never thought alcohol would be a problem in that district, you know. But this was recognized and brought to our attention by the community leaders, and using those kinds of support system, many things can be done to prevent mental and neurological and substance use disorders from going into chronicity, and also decreasing the problem within the community.
So thank you so much. Oh, I think somebody's trying to speak.
Is she?
Is there a question from the audience? Okay, it might have been a technical problem. So maybe I guess last question would be, what do you advise the participants today on improving mental health services?
Well, the participants, to start with, I would like to appreciate the participants because of their interest, because they are interested in helping the mentally ill. That's why they are attending this session. I will start by appreciating their presence and interest in mental health. And the next thing is really try to do to take this training. I think the Ministry of Health organizes such trainings, and if there is really need, it could be through EMA or other means. Our department is more than prepared or glad to train you with MHGAP and help you acquire the necessary knowledge and skill to identify and treat the mentally ill that you encounter your clinics, be it in private clinic or in public institutions, wherever you are. We can help you to build your knowledge and skill to help the mentally ill. And I would like you to be proactive in trying to acquire the necessary knowledge and the skill to equip you to help people that you encounter in your clinics.
So I'm seeing that Nehemiah raised one more question in the chat box. Major strides have been made and are being made in terms of mental health service over the years, but this progress seems to be resting on the shoulders of less than 100 people, with a relatively underwhelming international and local investment in the area. How can we ensure that these hard-made gains are built upon in the coming years?
Well, I must say, I'm very optimistic now because many people are getting interested. In terms of human resource development, we are really showing very good progress compared to other African countries. When we started our residency program and psychiatric nurses training program, the need was so great. You cannot imagine. Now we are really training so many psychiatrists per year. When we started our training program, Kenya had 56 psychiatrists. We had only 9 at that time. But now we are over 100, and I think 40, 50 in training, already in the existing universities. 2 universities are going to start residency programs this year. Through that, now I think we are progressing very well in terms of human resource. But other institutional preparedness to bring about change, systemic changes remain to be tackled, to be addressed in different institutions. So, and to enhance these different stakeholders, including NGOs, it would be really important to attract NGOs that work, so many of them working in this country, not interested in mental health, should be persuaded to support this effort of training so many people and integrating mental health service into primary care and different general health services, and also acquire the necessary supply, like different facilities and medication supplies, which are most of the time short. That's actually what I suggest should be done in the country, and we are good actually. I was actually thinking that mental health this time is in good hands, and it is high time for me to retire.
Okay, so Martha is asking if it's okay to get your email.
Sure, you can. I have given you the freedom to share it with anybody.
Okay, I'll share it in the chat box. So some of the participants might consider joining a study in mental health. It could be psychiatry or research. Any advice on that regard?
Yeah, well, if you are interested, actually, you need to, if you want to be a psychiatrist, it would be a delight for us to have you. It's unfortunate, though, this time that we have no, we are not in a position to make decision who we should take, enroll into our training programs. It is the ministry that decides who should go where and who should. Well, they give you exams, and depending on your grades, you'll be given your first choice, second choice, and third choice. That's what's happening now. In a way, I am sad that people are not able to get their first choice on one hand, and on the other hand, I am happy that there are so many interested young doctors now to do psychiatry. This is very exciting time. There was a time when we had only one resident, one applicant in our department. So in 1 year, we had only one resident. In another year, we had only 2 residents. Now we are being flooded with so many young, interested, intelligent doctors to do psychiatry. This is a very exciting moment for me. It's really, if I happen to write history of psychiatry in Ethiopia, I have a lot to say, having observed the change over the years in our country.
I think we would be excited to read that.
Yeah, I am thinking of doing that, Herman.
They're saying looking forward to your book.
Well, this is a slip of tongue, probably. So
we would be expecting it soon.
Okay.
So thank you so much for your time.
Something. Yeah, it's a pleasure.
We are very
it's a pleasure. Thank you, Herman, for inviting me, and I'm sure you have been instrumental in this invitation. So thank you very much, and thank you everybody for the attendance. And I look forward to seeing you as residents in our department or as colleagues afterwards. And this is a great moment for me in my professional career to see so many doctors being interested in mental health. If one of the stories that I would like to share with you in my book, which may come up in 20 years from now, is that we used to be so much, we used to feel so lonely and also discriminated, stigmatized because of doing psychiatry, choosing psychiatry as a career. There is one thing that I always tell my students, that many, many years ago, before we started residency program, I had with my final year students, we just finished our teaching session and we were chatting, and I asked the students, how many of you would be interested to do psychiatry as your career? And one of the students asked me back saying, Yavelandoi. And my response was, so I think this is a really very exciting moment, as I said, in my career, because of the progress that has been made over the years, and that tension that mental health has drawn to the policymakers and colleagues and young doctors and different professionals. So thank you very much for giving me this opportunity, Herman, and thank you everyone for attending and for raising those interesting questions.
There's a lot of thank yous in the chat box. Maybe one more thing is someone asked if materials are available to read. So I think we can communicate and I can share it with the attendant.
Yeah, sure.
All right.
Sure.
Thank you.
Actually, we can send you the articles of this study. There's a district study. There are so many of them. About 4 or 5 students have done their PhDs using this project, So they have produced enormous amount of material. If you are interested in those, I can send you. And I can also, it's good also to go to WHO website. You can get many free downloadable materials to read on these things that I was talking about. And some of the slides that I presented was actually stolen from the WHO materials. So you can find them there. And you will find so many different, very essential and important reading materials if you go to WHO website on the internet.
So thank you again. Yetina Wag team is asking if they can have you again in the near future, if possible.
Yeah, anytime.
Thank you so much.
That's what I live for. So yeah.
I know. Yeah. Thank you everyone for
It's a
attending.
pleasure. Okay. So on specific topics, if you want, that's also okay. And now this is very general thing, and we can discuss if that is an area of my expertise. I will be very much delighted to do this. And if I think of someone else who can do it better than I can do, I would also refer you to those individuals.
All right.
Because we're having so many different specialists nowadays, people who can handle things even better, much better than I can do. So I would be happy to do anything in my capacity.
Okay, thank you. Have a good weekend, everyone. Thank you, Professor.
Thank you, Herman.
Bye.
Bye-bye.